Good afternoon, everybody. Thank you, Amla, for giving me the opportunity to talk on this occasion. I'll be talking on management of uveitis with intravitreal injection. It's a small topic of uveitis, but of course it does play an important role. The drug which we use mainly are corticosteroids, which are the most commonly used ones. The other ones are anti-VEGF agents, which are gaining popularity nowadays. The other group of drugs are antibiotics and antivirals. The last group is anti-neoplastic agents. Corticosteroids are used in most cases where posterior subtenons have not been effective. So most of the posterior uveitis like refractive uveitic CME, variety of posterior uveitis like Behçet's, EVKH, serpiginous, etc. Here you can see a patient with bilateral intermediate uveitis with cystoid macular edema with vision of 612, 6/9 and gross cystic spaces in the fovea. Few weeks after giving IVT, you can see the dramatic response and restoration of the foveal architecture and back to 6/6 vision. So uveitic CME responds dramatically to intravitreal triamcinolone, and it is indeed a wonder drug for most of uveitic patients. But all drugs have their own side effects. Nothing is without any of the side effects. Corticosteroids have a high risk of complications of raising intraocular pressure of about 30 to 43%. Of course, in cases like hypotony, it's very useful to increase the intraocular pressure, but uveitic glaucoma is an entity which is quite difficult to manage, so you wouldn't want to have increased intraocular pressure. Cataract occurs in about 30% of the patients. The rest of the complications including endophthalmitis, which is quite risky with steroids. Advantages: it's a very reliable drug. You saw the quick effect within a couple of weeks. Patient is happy, everybody is happy, rapid response. There's no ptosis unlike posterior subtenon, so patient is cosmetically very happy. There's no systemic side effects of oral steroids, which can be in the long term very difficult for the patient. Disadvantages, like you saw, cataract and glaucoma is very common, and complications of any intravitreal injection like endophthalmitis. It has a temporary duration of effect, and if you accidentally inject in case of an infective uveitis, it can cause spread of infections. So what's the alternative which we have? We have nowadays Ozurdex, the dexamethasone implant, which is a biodegradable implant. It has a longer duration of action, anywhere between 3 to 6 months of duration. It's a solid polymer mattress containing 0.7 milligrams of dexamethasone. It biodegrades, as you see in this picture, into lactic acid and glycolic acid over the couple of next months. It's usually administered as an outpatient procedure, very easy to administer. The studies initially showed that there was significant reduction of vitreous haze, seen in about 46.8% versus 11.8% in the sham, and significant 3-line improvement from 42.9% versus 6.6%. So that's a very good result which you would like to have in uveitis. How about the complications? You can see it's about 25% IOP rise as compared to 30 to 43 of steroids, and cataract is only in about 5% as compared to 29% of steroids. It seems to be good, but the cost is quite expensive. It's about 40 to 50,000 per injection, and it may not last very long. You may need again repeat injections. The other implant which is available surgically modified is fluocinolone implant or Etisert. This has to be surgically inserted. It acts for a longer duration of action for 30 months, but 60% of them develop glaucoma and may need surgery in about half of them at least. And in 2 years, nearly all phakic eyes develop cataract. The next agent of choice nowadays instead of steroids is anti-VEGF agents. You have Avastin or ranibizumab and Lucentis, which is antibody fragment 5 to 10-fold higher. Of course, you have this constant risk of this is more cheaper, this is more expensive. This debate goes on. How does it act? First, in CME, anti-VEGF agents, we have found with studies that you have to use it in case-by-case patients, in patients who have refractive uveitic CME, and in which intravitreal triamcinolone is contraindicated. Here you see a 84-year-old female with idiopathic panuveitis and vasculitis, and showing remarkable restoration of the foveal architecture from 379 to 191 microns. That was with Avastin. And now how about Lucentis? This also shows with repeated Lucentis injection, you can see the good response in the OCT. Anti-VEGF agents also have a role in treatment of CNV in patients with uveitis. This is the largest studies conducted, 15 eyes from 15 patients. Multifocal choroiditis and panuveitis was seen in about 7 patients. The visual acuity improved in 80% and the foveal thickness decreased in about 87%. Here you see OCT of 5 patients pre and post injections. You can see that the foveal architecture is slowly being reduced and the CNV complex is slowly decreasing in size. So it does have a role in patients who have CNV associated with uveitis. Next group of drugs are antivirals. They are used as initial treatment in sight-threatening retinitis, especially when the fovea and optic disc is being involved. You can also use it as primary treatment in patients who are intolerant to systemic treatment, or in patients who cannot afford implants like in our country, or in CMV retinitis. It can be used as an adjunct to antivirals in aggressive diseases like ARN and PORN, especially in immunocompromised patients. The use of antivirals is slowly being reduced because of the use of HART and reduction in CMV retinitis rate. This has lesser systemic side effects. They have a longer duration of active, and this, as so far, it's the most cost-effective available treatment of choice for CMV retinitis. It's useful especially in zone 1 diseases. Disadvantage, because they're giving only in one eye, it's a risk for contralateral eye disease in about 11 to 30%. You also develop non-ocular end-organ infection in 16%. So all patients should receive systemic therapy with oral valganciclovir, which is very important, or with any other drug like IV acyclovir. The most common used drug is intravitreal ganciclovir. It's a virostatic drug, so you need to keep repeatedly giving the injection, continuous uninterrupted treatment for a long time. So the optimal maintenance dose is still controversial. You have a low dose which is about 0.2 to 0.4, but we don't know how effective it is in the long run. And high dose is 2 to 4. We don't know about the toxicity also in the long run. The duration of treatment, as a primary treatment in HIV, you have to go on giving for a long time till the disease subsides. Induction is about twice weekly and maintenance is once weekly injections. As an adjunct in ARN and PORN, usually till you see clinical resolution, median about 6 injections during 14 days are needed for these diseases. So here you see a patient with gross CMV retinitis involving the fovea and the disc. So in these cases, IV ganciclovir is very important because it's threatening the fovea and the disc. Here you see the remarkable improvement in the repeated intravitreal ganciclovir injection of CMV retinitis. What is the other choice? You have ganciclovir implant. This is a polyvinyl alcohol ethylene or ethylene vinyl acetate device. It releases the drug from a 4.5 milligram capsule at the rate of 1 microgram per hour. This is effective for about 9 months. It has to be surgically implanted. Once the effect of the drug is gone, you need to replace it after about 32 weeks, or you can place an additional implant through another different site in the pars plana. The second drug which can be used for antiviral therapy is foscarnet. This has an induction therapy of 6 injections of 2500 micron given at 72-hour interval, followed by a weekly maintenance injections. The dose is 1.2 milligram and 0.05 ml weekly. Cidofovir has been used earlier, but nowadays not many people are using because of the risk of anti-uveitis and hypotony. But there are some people who still continue to use cidofovir for CMV retinitis. As you see in the cost maintenance, because they have to use it for a long term, you see that intravitreal ganciclovir is the cheapest option and nearly very minimal compared to the other options which are available for CMV retinitis. The next set of drugs are antibiotics, usually for endophthalmitis and toxoplasmosis. Endophthalmitis is a recurrent, and there's another lecture going on in the other hall, so I won't be dealing with that. Going on to toxoplasmosis. This is the largest study done by Payman et al., where they injected 1 milligram of intravitreal clindamycin and 40 micrograms of dexamethasone. They showed significant reduction in vitreous inflammation, a decrease in the lesion size, and dramatic improvement visual acuity, very similar to the systemic treatment. Of course, there's greater bioavailability because you're injecting it very close to the lesion. They need fewer follow-up visits and fewer hematological investigations as compared to systemic therapy. But systemic therapy may be more beneficial in patients who are IgM positive for toxoplasma. Here you see a lesion which is beautifully resolved after treatment with intravitreal clindamycin and dexamethasone combination. The last set of drugs are anti-neoplastic agents. Methotrexate decreases the folic acid metabolism. It's used in the treatment of primary intraocular lymphoma and also in recurrent cases. Therapeutic doses in the vitreous remains for about 5 days. So you have an induction phase of 2 times weekly of 400 micrograms in 0.1 milliliter for 1 month. Then you have a consolidation phase, which is weekly injections for 1 month, and maintenance is monthly injections for 1 year. This shows 100% remission. It's a very, very effective drug. Of course, you have a lot of side effects: cataract, maculopathy, corneal epitheliopathy. You have to be very careful about the dosage of methotrexate because it can be quite toxic to the body. So be very careful with anti-neoplastic agents. There are other miscellaneous drugs like infliximab, which is a human anti-necrosis factor antibody, which has been useful in cases of uveitis and uveitic CME. So what are the future directions for intravitreals? Is the role for intravitreals in the future? Yes, we have a lot of developments going on in this field. They are trying to get small liposomes, which are phospholipid membrane-like structures, very small tiny vesicles, which can also be made temperature sensitive. So you have a small laser light or a microwave to have a controlled release, which is better. You have microspheres made of polymers of glycolic acid and lactic acid, implantable devices like polyvinyl alcohol and polyliposphere. They are trying to use cyclosporin for the treatment of posterior uveitis. You also have transcleral iontophoresis, where you use the drug delivery to the anterior posterior segment, and subconjunctival reservoir, which can be periodically refilled. These are all the future options available. So the procedure, I think most of us are quite familiar with. Preoperative antibiotics, some people use it, may not give. Most people nowadays give it in the clinic setting, not in the OT setting. Use of face mask I think is mandatory to prevent the respiratory infections to carry on. Povidone iodine is always a must. It's usually given in a 1 ml tubercular syringe with a 30 gauge needle, usually in infratemporal quadrant, so you don't have floaters in the middle. Postoperative antibiotics, most people do use it. Most significant side effect would be endophthalmitis, and commonly you have pain, etc. You're worried about other time's up. So this is a small procedure of the intravitreal injections. Can I skip it? So this is just a procedure of the intravitreal injections, how we can.
Eyelids of the affected eye. Swab the eyelids and skin surrounding the eye with 10% povidone iodine swabs. Start with the eyelids and continue with the surrounding skin. Proceed from medial to temporal aspects, making sure the eyelid margins and lashes are swabbed. After disinfecting the eye area, put a sterile ophthalmic drape over the affected eye. Then, apply the eyelid speculum underneath the eyelids. Wash the eye with 5% povidone iodine ophthalmic solution, making sure to cover the conjunctiva over the planned injection site. Then wait 90 seconds and wash with saline solution to remove the iodine. Now the eye is prepared for the injection of Lucentis. Direct the patient to look away from the syringe prior to giving the injection. Use the sterile eye caliper to carefully measure the scleral injection site 3.5 to 4 millimeters from the limbus. Insert the needle through the pre-anesthetized conjunctiva, aiming towards the center of the globe. Deliver the injection volume slowly and remove the needle slowly to ensure all of the drug is in the eye. For subsequent IVT injections, you should rotate the injection site. The patient should be prepared for injection by